Dr. Ankur Shah. He has keen interest in musculoskeletal radiology and especially complex structures. He has also published various papers on the same, and I would once again like to invite him on the dais.
Thank you, and I'm glad to be here again, actually on behalf of Dr. Gaurav, who was supposed to take this talk, but unfortunately because of some unavoidable circumstances he couldn't be here, and I'm taking on behalf of him about imaging of the Achilles tendon. So in 10 minutes we'll be seeing briefly about some anatomy of the Achilles tendon, the imaging modalities, what is the difference between the normal and abnormal Achilles tendon, and what are the various pathologies which we commonly come across in Achilles tendon. We know Achilles is the thickest and strongest tendon of our body, the Achilles, right? So it has to be a strong one. The origin, it is in the mid calf. It is formed by the two heads of the medial and lateral head of gastrocnemius, and along with that the soleus joints, and they all three together they form this tendon, which is the Achilles tendon. It has mainly two parts, the musculus tendinous junction as well as the tendon proper, because the injuries they occur at either of these parts. What are the imaging modalities? Just like any MSK part, we have plain radiographs, the ultrasound, and MRI. CT again has very limited role, but the modality of choice is ultrasound or MR, and we need to decide which modality to use from case to case basis. Plain radiograph is mainly for the screening tool to look for any underlying bony pathologies like any fracture, or to see for the osteophytes or some calcification in the tendon. We can see some indirect evidence of the Ksgars fat pad, but otherwise the overall value of plain radiograph is limited. Ultrasound is a wonderful modality so far as the Achilles tendon is concerned, because it is a superficial tendon and we can see it very nicely with the help of ultrasound. The issue is it is more operator dependent, so you need to have a good person doing the ultrasonography. It understands for MSK ultrasonography, you need to understand the anatomy as well as the variants properly, otherwise it becomes difficult to scan. The advantage is that you can do a dynamic study with movement of the tendon, and we can evaluate the tendon at the same time, and it is easy to follow up or easy to do comparison also. So whenever we have doubt, we have the other leg also by the side, so we can compare both the tendons, and it is much easier to identify the pathology. MRI is excellent diagnostic tool, just like any other joint or musculoskeletal part. It has better soft tissue characterization, as well as it can give us details of the osseous abnormalities also, that it is not operator dependent, and of course we can get the multiplanar imaging, though at some added cost compared to the ultrasound. So which is the investigation of choice? Should we do an ultrasound or do an MR? Always it is better to discuss the case with the orthopedic surgeon or the physiotherapist or the treating interventional radiologist before doing the scan, so that we can decide which is better for a given patient and do accordingly. So as I said, both have their pros and cons, and we need to decide which would be better modality for a given patient or a given condition. The most abnormalities of the tendo-Achilles, they occur because of the trauma. It can be either trauma by the sharp injury like glass or knife injury, or the road traffic accidents. It can be because of the tractional injuries, or because of the overstretching of the tendon, or many of the times it can be because of the chronic abnormalities like repeated stress, which occurs particularly in the athletes or in the joggers or runners. And what we need to see is, we need to see for the tendon rupture, whether it is partial or complete. We need to see for the intrasubstance changes, to see for the hemorrhage or fluid collection or edema within the tendon, and the peritendinous changes like inflammation or fluid collection. So there is a classification of which is most commonly used is the 𝙂𝙚𝙗𝙪𝙡𝙀 classification for the tendon tear, which also gives us idea about what would be the better management for a given condition. So if the rupture is partial thickness, which is less than 50% thickness, then usually the treatment is conservative, while complete rupture, if it is small one, then end-to-end anastomosis can be done. If the defect is larger, more than 3 cm or more than 6 cm, then we need to have a tendon graft or a synthetic graft. So ultrasound or MRI, they help in evaluation of whether the tear is partial or complete, and if it is complete, then what is the extent of retraction and what can be the further treatment which can be planned in a given patient. So the plain radiograph, it doesn't show much, but on ultrasound you can see the full thickness defect in the tendon, and we can easily measure the retracted part of the tendon, which can be a small one, or it can be, there can be a large gap like here. And as I showed, the further management is based on the size of the defect. MRI, it gives same information. You can see the torn retracted ends of the tendon. We can measure the distance between the two ends and again decide about the further management. So it can be a large area of defect, there can be fluid collections at the site of defect, and all those information are very easy to get on the with the help of MR. So again, ultrasound and MR, both these correlate very well. At least for the Achilles pathologies, the results are almost similar, and we can see the size of the defect very nicely. You must have heard about conditions, the names like tendinitis or tendinosis. What is the difference? The tendinitis, itis as it suggests, is inflammation, so it has to be an acute condition, just like appendicitis or cholecystitis. So tendinitis is an acute condition where there is significant inflammation of the tendon, while tendinosis is a chronic condition. So sometimes the tendinitis, if it is not treated, then over the period of time it gets converted into the tendinosis. So the tendinosis or tendinopathy, the most common cause is over-exercise or the repeated trauma to the tendon, and not just the acute trauma. Particularly seen in athletes or basketball players, where there is enlargement of the tendon, there is disruption of the fibrillar pattern and increased vascularity within the tendon. And this is one reason why ultrasound, it even scores over MRI for evaluation of the Achilles tendinopathies, because MRI does not show the loss of normal architecture of the tendon, which is better seen with the help of MR. We also need to see what is the location of the abnormality, whether it is insertional, that is around last 2 centimeter, terminal to 2 centimeter of the tendon, or it is pre-insertional or mid part of the tendon. So as I said, for tendinopathy, the investigation of choice is ultrasound with color Doppler, which gives us details about the tendon. What do we see is usually the anteroposterior diameter, it increases more than 1 centimeter, and you can also see abnormality in the adjacent peritendinous soft tissue, that is the 𝐾GAR's fat pad, with increased vascularity. As you can see here on the ultrasound, the normal architecture of the Achilles tendon is lost, it is enlarged, heterogeneous, and you can even here see the insertional part of the tendon, which is thickened, and you can see increased areas of vascularity within that. That is the classical of Achilles tendinopathy, which can be either non-insertional or insertional, as in this case. MR, again, it showed same picture. There is enlarged tendon in the distal part. You can see areas of hyperintensity on the fat suppressed T2 weighted or proton density images, and adjacent edematous changes in the 𝐾GAR's fat pad also. So both the modalities can give us excellent details of the Achilles tendon abnormalities. A few other abnormalities which I won't be going in the detail to lack of time, but they are Haglund syndrome, like here. There is an osseous prominence which leads to the Achilles tendinosis with partial tear of the tendon. There can be different degenerations like the mucoid or the hypoxic degeneration, which are non-traumatic, but the tendon is enlarged and shows areas of the fluid intensity within. There can be xanthomas within the tendon, which shows significant enlargement of the tendon, and sometimes other conditions like rheumatoid arthritis or gout can also affect the Achilles tendon. So to take home, understanding of anatomy and imaging modality is extremely important for the Achilles tendon. We need to identify the difference between the normal tendon and the abnormal tendon. Always discuss what do you want to look for to decide the proper imaging modality, and so far as possible try to follow up the patient with the same imaging modality so that we can give the comparative results. Thank you so much.